For inviting me. So we went through the guidelines, the suitability, and the imaging. So my talk will be more about engagement. We know that the guidelines tell us what should we do. The registry is telling us what we are doing, and now the cases are showing us how we're pushing the boundaries and trying to bow those rules. So we know that it's already been covered that MR is bad, it is associated with mortality, and decreasing it as much as possible is best. And as we went forward from 2005 until now, we have seen there is a decrease in the adverse event associated with the device up to like less than 3% now. There are patients factors that we have to consider to have a good outcome, and my talk is about challenging cases. So always keep in perspective the clinical factors, the baseline of the echo, and the procedural factors. So let's talk about a few scenarios. Let's talk about the transseptal puncture. I mean, it might be easy, it might be simple, but actually when we talked about previous question about what is a high volume center, it is recommended that at least the operator is doing more than equal 10 transseptal puncture before embarking on mitral clip. So when to abort? So this is a case I'm just delineating that it happened during the pandemic area, early stages, and everyone was trying to avoid any aerosol procedure. So we thought just from screening, it's just a severe TMR, patient is symptomatic. We thought, well, the transthoracic looked good. There is some, prolapsing element going on with it, but I think we can go for the procedure without the screening. Well, it wasn't a good decision. So here we are in the procedure, and we've been trying to get a transseptal puncture in the patient. And you can see out of the back that the imaging is not the regular short axis delineated in the right side of the picture here. And we've been trying, and you can see even in the bicomitral view, which is where the people who understand in the mitral clip, that we couldn't see the left atrium at all. We tried multiple for 40 minutes trying to get just like in a good image to have a good transseptal, and we failed. And we found out the transseptal height wasn't suitable for the patient, and the LA was so small, and therefore we aborted the case. Message taken, screen your patient, don't try to take shortcuts. So I did the transseptal in another case, and now I'm considering, how can I cross? Looks good, the heights are fine, everyone is happy, but unfortunately I couldn't cross even the SL1 catheter. So despite having, this is like an 8.5 French, we couldn't cross with it. It's just the dilator is going in. We introduced the extra stiff wire. You can see it's outside the silhouette of the heart, so it means that you're in a pulmonary. And we started with escalating ballooning. We took a 10 by 60, we ballooned a bit, and then we took a 12 by 30. At that time, we were using generation 3 of mitral clip, so it's equivalent almost to 24 French. So you can see out of the back, it's a bit here bendy, but it facilitated the procedure afterward. You can see the guide is ready there, and this is we introducing an XT in a patient. And another point here, when you go, try not to change your trajectory as you're going in, because already we were a bit, I think, inferior because of this difficulty in crossing, so don't make your case more complex. Another challenging, we have, when she talked, Dr. Rasha, about the suitability, we talked also about a flail. So try to catch me. This is a case I've done in 2019. He's a 93-year-old gentleman, and he was already, from the echo and his blood work, you can see it was like a flail anterior mitral leaflet. His kidney function wasn't that great, and he was symptomatic. Keep in mind, this is a very active guy. You can see out of the back that he have a severe mitral regurgitation, and it's already swirling everywhere. And from the LVOT, you can see how the flail leaflet is here, and the challenging of the posterior that she just delineated for us, Dr. Rasha. From the 3D upside down, you can see it. It's very hard to see the posterior leaflet. It wasn't an easy case, nevertheless, but the plan was to go for in the middle exactly and catch the flail gap, flail leaflet here segment in the A2P2. One of the things that it was said, questioned in, like, when do you think that is enough after doing the procedure? We started to go with hemodynamic and measuring the systolic flow reverse and the pulmonary vein, and having a good dynamic response intra-procedurally and also post-clipping, it can give you at least a prognostic value, and that you maybe have done well, even if the result may be a bit in the moderate or less. But get as much as possible, of course. We talked about difficulty in imaging, just not, let's say, to catch the flail, it was also a difficult imaging situation. You can see here we're trying to get the flail segment. It was an XT. And we've been trying, I think this took us like at least 40 minutes to have a good grasp. Every time we're getting, it's not about just getting it, you have to have a good bite of the leaflet. So you have a secure insertion of the leaflet. Otherwise, you will end up with a single leaflet detachment. You can see this is after. You can see the mobility in the anterior leaflet has much, much improved. And the transgastric wasn't adding much of an info or data, but usually we use it at the end to confirm the position and if there's any pericardial effusion. You can see out of the back how mobile is the leaflet and the clip, and it's advised in this situation in flail to put the second one to stabilize it. And this is the results afterward. You can see how good the MR reduction. Patient lived, by the way. He developed COVID pneumonia in early 2020, survived a 1 month of intubation, and he survived a stroke. And I saw him 2 months ago, and he's still walking around and attending his farm. So what about device-related issue? This is a good paper talking about procedure-related device-related issue, and we'll just touch bases on simple stuff. We talked about the mitral stenosis, persistent of MR, or device failure. You have to consider in the experience of the implanter, and you have to plan it. Without plan, you may fail. So we talked about having a good area. We talked about don't leave an MR behind you, and don't leave a gradient behind you. Don't be perfect because the enemy of good is perfect. So look at don't leave a mitral stenosis behind you. Look at the area and make your measurement. So pre-procedural risk factor to develop a post-procedural mitral stenosis usually is the area. And numbers are going now with 4. So this is a case if I have a patient who had a clip or edge-to-edge repair in July of 21, but we used the 2 Pascal P10s. For those who are not familiar with it, it's more like the bulky one. In June, when she came, actually she was non-ischemic cardiomyopathy with ejection fraction of 30%. We measured the area, looks good, area is 5.8. Let's put a device. We have a gradient of 1 with the first. Let's put a second to delineate and remove any MR behind us. You can see out of the back the difference in the bulkiness. We measured interprocedurally. It was 3 at a heart rate, I think, of 58. Okay, everyone is happy, no much of an MR, no much acceleration, everything is good. Next day, well, what is happening here now? What is this in the 4-chamber view? We have a good MR reduction, but boom, the mean pressure is 10 now. So, but it was a heart rate of 78. So we attributed maybe with the blood loss and some uncontrolled heart rate and pressure that maybe this is the leading of the mean of a 10. Again, that's not a good thing, by the way. So the patient came in December, and she was admitted for, some electrolyte imbalance and some hypoglycemic attack. And we found that there is some MR happening here, but whatever was going on in terms of the gradient is not anymore there. Ejection fraction improved from 30 to 35%. Hemoglobin was almost better, and the mean gradient was 7. Still, the heart rate was in the 70s, I think, when the time it was done. So, key message, correct the underlying element issues of the patient's factor, and look very closely in terms of the choice of the device and the area. So this is the predictors of mean mitral valve gradient, and you can use this. They use the CT, but you can use a 3D to help you when having the anterior, posterior, and medial to lateral. As long as you're in this area, you'll be fine, most likely. What about the strategy? So we talked about cliff, that maybe it's not a suitable situation. Those cases I'm presenting now, they happened last week. So I have a patient here with the cliff usually more in the lateral, because this is the aorta, this is the lateral, this is the medial for those, and you can see there is already 2 jets, okay? So, but the bigger jet is more in the lateral perspective of the case. So this is what I do with my team. Usually we come and we froze it and we start putting clips in the screen. This is our plan. What should we do? Should we go like this or should we go like this? And we start to debate, and then we crop the 3D and we go frame by frame to know exactly where is the bigger jet. So this is what we've done, and you can see it's just a very teeny tiny squirt coming from the lateral perspective, and hemodynamic, we have a 50% reduction in the V wave with no much gradient, and pulmonary, it was good. Second case in the same day, same situation, we have 2 jets here, we can see here, bit difficult imaging, we had to go off axis, but the cliff now this time is coming from the medial perspective, but the jet is coming actually from this side, from the lateral side. So this is what we decided. We will go from this here. And that's what we did. But in this case, you can see it's more degenerative. The area was like, if you pushed it, it was 3.6, but actually it's maybe 3.4, 3.5. You can see the moment we choose a smaller device, though we have the luxury of having a big leaflet and long leaflet, but we choose an NTW in this situation because we needed some broadness, and at the same time, we don't want to compromise the gradient. There is a small jet here, but we have accepted because the gradient will not tolerate it. The gradient next day was 5 at the heart rate of 75 with mild plus MR. Second thing, don't get stuck. So we can see here, this is like an MR case, but you can see how much of chords are happening and how much is the posterior is tethered here. So you can look at it and see more focus. So this is where planning is very important and to have to be taken in consideration because you have to come with a trajectory going like this. You don't want to come this way and get stuck here, or you come this way and you get stuck here. So spend 20 minutes in the LA, 2 minutes in the LV, much, much better than spending 5 minutes in the LA and 3 hours getting out of the LV. So this is the MR, and this is the 3D. You can see out of the back it's more central situation, and that's what exactly we did. But yet, despite all our attempts and using a smaller device of an NT, still we got kind of like a pull posteriorly here. And that was like another 20-minute discussion. It was just a single grasp. It wasn't multiple grasps. But we have an issue. Why is the clip doing this? So we have an argument. You have an MR reduction? Yes, I have an MR reduction. Do you have a gradient? No, I don't have a gradient. So it means, in other words, you didn't distort the valve. So you can have a breath and take a look. We did multiple 3D, multiple view to exactly know, is it this chord that was pulled or where exactly? And we looked at the hemodynamic. It also was responding very well. We did also measurement to know exactly. This is a pre-clip insertion. You can see it was 3.5. And then the second after it, we measured it. It's 2.7. So you have a good 7 millimeter inside. So because one of the concern was you don't have enough of the anterior. And the beauty of Generation 4 that you have independent grasping and you can amend your positioning. So this is our 3D afterward. Gradient is good, which is assuring, and you have a pulmonary flow good. Clip embolization can happen, it's rarely, and that's why we said don't get stuck or don't get away. So this is a previous case that happened, and not mine, courtesy to the one who did it, but because you can see how flimsy and moving, I think they were trying to stabilize the clip, but unfortunately just got away and got the patient presented with an inferior MI. Another embolization may went to the femoral and they started to do it, or actually here, the axillary. Or another case, they embedded inside of the LV, and it's an XTW. So SLD, you have to take in consideration all of that. So as I said again, trajectory planning. Another case here where they tried to, where's the clip? There you go. They tried to get it. They got it from the LV, and they took it through the aortic valve. They tried to go here from the femoral. This is like a 21 French, but unfortunately it flipped and started moving downward to the other side. Though they dragged it to the common femoral for the surgeon's vascular to remove it. So take-home message. Patients with high surgical risk here have been established to be a safe procedure with a very low adverse events compared to mitral surgery. MR reduction depends on the implanter experience and to identify the optimal strategy for each pathology and to select the most favorable clip size or kind. With that, I conclude my talk. Thank you, everyone.